Telotristat for refractory carcinoid syndrome diarrhea, a new option when standard treatment isn't enough. Hello, this evidence-based content is prepared by Sabur Khan, fellowship-trained consultant surgeon, and if you or someone you care about has been dealing with carcinoid syndrome diarrhea that just won't respond to the usual treatments, you're in the right place. I know when you're experiencing persistent bowel movements despite medication, it's not just inconvenient, it's exhausting and can completely disrupt your quality of life. Today we're going to explore Telotristat Ethyl, a relatively new treatment option specifically designed for this challenging situation. By the end, you'll understand exactly how this medication works, what the research shows, and whether it might be the right next step in your care. Before we dive into Telotristat, let's establish what we're dealing with. Carcinoid syndrome occurs in around 20 to 30% of patients with neuroendocrine tumors that have spread to the liver. The classic symptoms are secretory diarrhea and flushing, both caused by the tumor releasing excessive amounts of serotonin and other bioactive substances into the bloodstream. Now, most patients initially respond well to somatostatin analogs, medications like octreotide or lanreotide. But here's where it gets challenging. Refractory carcinoid syndrome means your symptoms persist or recur despite these standard treatments. We're talking about recurring diarrhea, continuing flushing episodes, and persistently high levels of 5-HIAA, the breakdown product of serotonin we measure in your urine. Telotristat Ethyl is an oral inhibitor of tryptophan hydroxylase. Now, what does this mean in real terms? Think of it as blocking the factory that makes serotonin. Tryptophan hydroxylase is the rate-limiting enzyme, essentially the critical step your body needs to produce serotonin from the amino acid tryptophan. By inhibiting this enzyme, Telotristat reduces the amount of serotonin your tumor can produce, which in turn should reduce your symptoms. What's particularly interesting here is that, unlike somatostatin analogs, which work by blocking serotonin release after it's already made, Telotristat stops it from being manufactured in the first place. The evidence for Telotristat comes primarily from two major clinical trials, with TELECAST being the Phase 3 study that led to its approval. Here's what you need to understand about these findings. Patients with refractory carcinoid syndrome who added Telotristat 250 mg 3 times daily to their existing somatostatin analog therapy experienced significant reductions in both bowel movement frequency and urinary 5-HIAA levels. In the TELEPRO study examining real-world use, patients reported meaningful improvements in their carcinoid syndrome symptoms after starting Telotristat. The medication was generally well tolerated, with the most common side effects being nausea, abdominal pain, and elevation of a liver enzyme called gamma-glutamyl transferase. But here's something important to note. Flushing was not significantly improved. You might be wondering why that is. The answer comes down to what causes flushing versus diarrhea. While diarrhea in carcinoid syndrome is predominantly related to serotonin, flushing is caused by other bioactive compounds that the tumor secretes, substances like tachykinins and histamine. Since Telotristat specifically targets serotonin production, it's most effective for the serotonin-related symptoms, particularly diarrhea. The standard dose is Telotristat Ethyl 250 mg taken 3 times daily, and this is added to your existing somatostatin analog treatment. You don't stop your octreotide or lanreotide. According to the European Neuroendocrine Tumor Society 2024 guidance, Telotristat should be added to somatostatin analogs in patients with refractory carcinoid syndrome when predominant diarrhea is the issue. Now, if you're wondering when exactly this becomes appropriate, here's the clinical scenario. You're already on standard doses of somatostatin analogs, but you're still experiencing more than 4 bowel movements per day, or your urinary 5-HIAA levels remain persistently elevated. This is classified as aggressive refractory carcinoid syndrome, and this is when your multidisciplinary team should seriously consider Telotristat. If you're supporting someone through this decision, it's worth knowing that Telotristat represents a specific escalation step in a treatment algorithm. Other options at this stage might include increasing the dose of somatostatin analogs, adding interferon alpha, or considering liver-directed therapies if there's significant liver tumor burden. The choice depends on the individual situation, disease progression status, predominant symptoms, liver involvement, and the presence of carcinoid heart disease. Let me be clear about what Telotristat cannot achieve. As I mentioned earlier, it has a limited effect on flushing because flushing isn't primarily driven by serotonin. The TELECAST trial demonstrated that while diarrhea and 5-HIAA levels improved significantly, flushing episodes did not show the same degree of improvement. Secondly, Telotristat is specifically for symptom control. It's not an anti-cancer treatment. It doesn't shrink your tumor or slow disease progression. The European guidelines make this distinction very clear. Patients with refractory carcinoid syndrome often need separate strategies for tumor control versus symptom management. You might need peptide receptor radionuclide therapy for disease control, while Telotristat addresses the quality of life impact of persistent diarrhea. If you're caring for someone with refractory carcinoid syndrome, here's something crucial to understand. The treatment approach needs to be multidisciplinary. Symptom control with Telotristat might make daily life manageable, but you still need oncology input for tumor-directed therapy, cardiology assessment for potential carcinoid heart disease, and nutritional support, because severe diarrhea can lead to malnutrition and electrolyte imbalances. First, if you're experiencing persistent diarrhea despite somatostatin analog therapy, we're talking more than 4 bowel movements daily, document your symptoms carefully. Keep a diary for at least 1 week, noting the number of bowel movements, their timing, any triggers you notice, and how they're affecting your daily activities. This concrete information is invaluable when discussing escalation options with your specialist. Second, understand your current 5-HIAA levels. Your team should be monitoring urinary 5-HIAA regularly, typically as a 24-hour urine collection. If these levels remain elevated despite treatment, that's biochemical evidence of inadequate control and supports considering Telotristat. Ask your doctor what your current levels are and how they've been trending over the past few months. Third, assess the impact on your quality of life. Refractory symptoms aren't just about numbers. They're about whether you can leave your house comfortably, maintain work or social activities, and sleep through the night. If carcinoid syndrome is significantly limiting your life despite current treatment, that's a legitimate reason to discuss treatment intensification. My diarrhea continues despite my current somatostatin analog dose. Could Telotristat be appropriate for my situation? What are my current urinary 5-HIAA levels, and how do they compare to when I started treatment? Are there any contraindications in my case, like liver function concerns, that would make Telotristat unsuitable? If we try Telotristat, how long should we expect to wait before seeing improvement in my symptoms? Should we also be considering dose escalation of my octreotide or lanreotide, or are there liver-directed therapies we should discuss? Now, if you're supporting someone through this, here are questions you might want to help them ask. What monitoring will I need while taking Telotristat? The answer should include periodic liver function tests because of the potential for gamma-glutamyl transferase elevation. You should request review by your neuroendocrine tumor specialist team if you are experiencing more than 4 bowel movements daily, despite somatostatin analogs. Your symptoms are significantly impacting your ability to work, travel, or engage in normal daily activities. You've had recent weight loss or signs of malnutrition related to severe diarrhea. You are experiencing new symptoms like worsening fatigue, shortness of breath, or leg swelling, which could indicate carcinoid heart disease. Your current treatment regimen isn't being managed by a specialist multidisciplinary team. Refractory carcinoid syndrome genuinely requires expert input from endocrinologists, oncologists, surgeons, interventional radiologists, and nuclear medicine physicians working together. Importantly, if you develop severe flushing, rapid heart rate, severe diarrhea with low blood pressure, or significant facial and lip swelling, particularly in the context of stress, surgery, or procedures, you may be experiencing carcinoid crisis. This is a medical emergency requiring immediate hospital assessment and intravenous octreotide. Don't wait if these symptoms develop acutely. Let me quickly recap. Telotristat Ethyl offers a targeted approach for refractory carcinoid syndrome diarrhea by blocking serotonin production at its source. Your next step: discuss with your neuroendocrine specialist whether your symptoms warrant adding this medication to your current regimen. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.